All right, everybody. Welcome to Disorders of the Head, Neck, and Face. So this is just sort of a smattering of disorders. Some of the more likely ones that you are to see. There are actually quite a few head, neck, and face disorders. So let's get started. We do have a PowerPoint that goes along with this. And here we are. I'm in your D2L. So the first one that we begin with is actually whiplash. Whiplash is what's known as a cervical acceleration deceleration injury, or CAD injury. Sometimes you will see it abbreviated instead of written out like cervical acceleration deceleration. Okay, basically what happens is your neck flips back really quickly and then stops and comes back, and that creates pain and injury within the structures of the neck. Now, this is most commonly caused by car accidents, motorcycle accidents, bike accidents, those kinds of things, but can be caused by a lot of other types of things. Falling down the stairs, or what else? Oh, roller coasters, things like that. Rides can cause your neck to whip back and forth. Now, it doesn't just have to be front to back, it can also be side to side. And you can also get jaw lash, where the jaw flips back and forth as well. So there's a lot of associated injury with whiplash, so more than we actually have time to talk about now. It can affect the muscles, the ligaments, the nerves, and even the blood vessels in the neck. So let me just show you real quick. Remember, you had that vertebral artery that was in the transverse processes of the cervical vertebrae. Well, imagine if the transverse processes are moved back and forth really quickly, or even side to side really quickly, you can get some tearing of the vertebral artery or even the carotid artery, though that is rare. But you can't assess the extent of the injury without a doctor or going to the ER or something like that. Okay, you might think you're okay, but you don't really know if there's a small bleed or if there's a small tear, or one of the ligaments is damaged, something like that. You wouldn't necessarily know right away. Okay, so the muscles that are involved, that's a little easier because you can feel it. Trapezius, SCM, splenius capitis, actually the scalenes, like longus colli, longus capitis, all the muscles in here are going to be strained. Now, of course, you know that a strain is an injury to a muscle or a tendon. So anytime the head goes back and forth really quickly, you're going to strain these muscles. And again, this is just a couple of muscles, but there are more that are going to be injured. That you will feel within the first 24 to 48 hours. Your neck will start to stiffen up and it will hurt, and you will remember, oh, right, I was in a car accident and now I'm feeling it. So the symptoms are pretty standard. It's going to be pain, decreased range of motion, swelling, headaches, bruising in the area, depending on what exactly you did. The thing is, there are degrees of whiplash, just like there are degrees of disc degeneration. And I believe they're graded 1 through 4. However, nobody other than osteopaths maybe, or ER doctors actually grade the whiplash like that. So if a client comes in and says, I was in a car accident, I was diagnosed with whiplash, they're not going to know what the grade is. And even if they did, it doesn't really matter to you. You just need to know that 5 is worse than 1, right? So if an individual had a pretty severe whiplash, they might have some radiculopathy. If you recall, that's, radiating pain. Obviously, if or if your client was in an accident or something like that, or had an injury, they are probably going to have x-rays. They may have had an MRI or a CAT scan or something like that. It is important to get those tests after an incident like that, because like I said, you don't know what is injured in there. You won't feel it right away. And a couple days, weeks, maybe later, you have this intense pain and you're not sure what's going on. Well, now you don't really know because you didn't have that X-ray or that MRI or CT scan or something like that. So what else would they do? Well, they'll probably give you painkillers because it is going to hurt. Anti-inflammatories. What else? Oh, muscle relaxers. Yeah. And may put you in a cervical collar. Those are the white puffy collars. The cervical collar doesn't really do anything other than stabilize the area, but your neck muscles are going to do that anyway. So you don't necessarily need the cervical collar after the first kind of 24 to 48 hours, because honestly, your neck muscles are going to tighten up in response to that injury to prevent further injury. It is a protective mechanism that your body does. The cervical collar really is only for muscles that have been loosened up by the muscle relaxers or within that first 48 hours before that swelling and hypertonicity take over. Okay, so basically what this slide says is that the body is going to protect itself naturally. Okay, so it gives you pain to prevent movement and further damage. The muscles are sore because of the strain sprain that occurred. And the swelling is due to inflammation, which is there on purpose. Your body's chief repair mechanism is inflammation. It controls the bacterial population that arrive to eat the dead tissue, dead torn tissues, and also the histamine initiates the swelling in order to stop bleeding in an area. So it swells the blood vessels so that they start getting sticky and bleeding. And well, without going into that, we'll go into that in physiology. I'm getting ahead of myself. Anyway, long story short, all of this is for a reason. So it's your body's way of preventing further injury and healing the injury that's there. That's why it swells and that's why it hurts. So as far as allopathic is concerned, chiropractic might help if the bones became subluxated during the accident. And of course, massage is going to be indicated, but not at first, okay? At least 72 hours after the accident, if not more. The thing about whiplash is you could feel absolutely fine for maybe the first week, and then the second week, you start to get pain and swelling, tenderness. You wake up and all of a sudden you can't move your neck. You know, whiplash is one of those things that can kind of creep in a little bit later. Even up to a year later, you can still have symptoms of whiplash. So right away, we cannot touch the neck. And again, this is mostly due to us not having MRI vision. We cannot see what's going on inside the neck. We do not know which structures are damaged, and we don't know if the work that we're going to do is going to further injure those structures. So we must wait until it is healed, okay? All right, so one last word about whiplash. You will see people with whiplash. I mean, this is a common problem in massage therapy because, you know, it produces headaches, it produces pain, it drives people to seek out massage therapy. So no doubt you will work with somebody with whiplash, okay? The second one we have here is Bell's palsy, or Bell palsy. You'll see it written both ways. This is a unilateral paralysis of the face due to a dysfunction of the facial nerve. So remember, the facial nerve is the one right by the ear, okay? It's the one that exits the cranium and then comes around to the front of the face and innervates most of the facial muscles on that side. So you have one over here and you have one over here. That's why this is unilateral 99% of the time, because only one of those facial nerves is affected. So this side or this side, very rarely both, okay? And what causes this? Well, it can be idiopathic. In fact, it's idiopathic a lot of the time. You can actually just wake up like this. And let me show you what it looks like real quick. So having one side of the face paralyzed. That's what it looks like. So you see the drooping of the side of the mouth, the drooping of the eyelid. You cannot use any of the facial muscles that are innervated by the facial nerve, which means that you can't produce facial expression on that side of the face. Okay, you can still use your masseter and things to chew, and some of the other muscles that are innervated by different nerves or that have dual innervations. Some of them do, but the facial expression on that side, gone. Okay, so that's what I mean by facial paralysis. It's a unilateral paralysis. You can wake up like that. It can be caused by severe stress, or it can be caused by a reactivation of the herpes virus. So if you've ever had a variation of the herpes virus, and there are a lot of them, the thing about the herpes virus is that it likes to go dormant along nerve roots. So it can reactivate whenever it feels like it, and you won't know. So yay. Reactivation of the herpes virus can cause Bell's palsy because it'll reactivate along the nerve root and create inflammation within the nerve itself, and that's what causes the paralysis. So as I mentioned, it's inability to control the facial muscles. Massage is indicated, but only for palliative purposes. And what I mean by that is you're basically just keeping the tissue healthy, and you're keeping the muscles well lubricated and getting rid of waste products and bringing in fresh oxygen and nutrients through the blood supply. But you're not actually helping the Bell's palsy at all. Okay, you can't control that, nor can you help it with massage, but you can help the muscles stay healthy. Most of the time it clears up soon. Yes, for most people it resolves within 3 months. However, you can have it for a year. Hopefully you're not that person that has it for a year. Okay, so again, unilateral paralysis of the face caused by the facial nerve, which is cranial nerve 7. Cranial nerve 7. You'll see the Roman numeral VII, that's 7. That indicates the facial nerve, okay? Torticollis is up next. Torticollis is known as stiff neck or wry neck. Let me write that one down. Wry neck. W-R-Y. Ooh, that is the worst Y ever. There we go. W-R-Y. Yikes, that's not very good. But anyway, stiff neck or wry neck is what this is called. Torticollis obviously is the name of it, but it's a unilateral spasm of the SCM. So one side of the SCM spasms, guess what happens? Yeah, the head turns to the opposite side because remember, this is a contralateral rotator. So you either slept wrong, which is sort of 90% of the time what happens. You slept with the air blowing on you, like having a fan blowing on you when you sleep, or sleeping under an air conditioning vent or something like that. A lot of times we're not aware of it, but we'll instinctively try to move away from the air that's blowing. So we're engaging our SCM to turn our head to the opposite side, and it gets stuck like that. Any kind of trauma to the neck, like whiplash, could cause this. Massage is definitely indicated, for sure. However, it's not indicated on infants. And I know that sounds really weird. Like, why would you be doing SCM work to infants? Well, I've actually seen it. I've seen infantile torticollis. Now, infantile torticollis is something completely different than this. It is not caused by tight muscles at all. So obviously massage wouldn't work. Okay. Infantile torticollis does need to be corrected. Sometimes the child will grow out of it, sometimes they don't, but you don't want to take that chance because if the head is constantly turned to one side, it actually starts to damage some of the structures around the neck and face. So, like I said, it does need to be corrected. However, on adults, totally indicated because we're working on the soft tissue. We're working on SCM. And I'm looking at page 244 if you need to refresh yourself on SCM. I couldn't remember the page number, so I had to look it up. SCM, okay? Usually clears up quickly. I've seen this maybe twice in my practice. I've actually seen infantile torticollis once. The mom wanted me to work on her baby. I said yes, but I just gave it a general massage just because I wanted to play with baby. I didn't charge her either. All right, and last but not least, we have TMJ syndrome. So let's go to page 235. That is 325. Okay, just kidding. 235. Here we are. Okay. So we're taking a look at the temporomandibular joint here. So here's the joint capsule, and remember which muscle attaches directly to the joint capsule? If you said lateral pterygoid, you are correct. Good job. Pat yourself on the back. Good. Okay, we also have ligaments in here. We have the sphenomandibular ligament, which attaches to that little part of the sphenoid bone and then to the inside of the ramus. We have the stylomandibular ligament. That one attaches to the styloid process. So we have a couple of ligaments that actually hold the joint or hold the mandible in the joint space. But the joint capsule and the lateral temporomandibular ligament here are the ones that really hold that joint together, okay? So TMJ syndrome, everybody has TMJ, right? Everybody has a temporomandibular joint. In fact, we have two of them. But the syndrome is inflammation of that joint that produces symptoms like difficulty chewing or clicking or popping or pain. You can get earaches, you can get headaches from TMJ syndrome, from that inflammation, and you can get malocclusion from it, or malocclusion can be a cause of TMJ syndrome. So a lot of you know if you have it because you hear a clicking when you chew, or your jaw doesn't open quite right, or when it does, sometimes it gets stuck. If that's ever happened to you, that is a slight dislocation of the temporomandibular joint. Yikes. So the causes of this are varied, but misalignment of the jaw, so you're kind of born that way, like your teeth maybe didn't come in quite right, or one side of your mouth is a little larger than the other. It's very common, actually. Grinding of your teeth, especially at night, that's a big cause of TMJ syndrome. Masseter trigger points, so having one side of the masseter be tighter than the other side can cause the whole jaw to be pulled to one side. So a lot of different causes, okay? As far as what can be done for it, allopathically, they just tell you to wear a mouth guard, especially at night, so that you don't destroy your teeth, but that doesn't stop the TMJ at all. You're still biting. So it's really a Band-Aid. Chiropractic adjustments. I've had my TMJ adjusted one time, and that is the last time I'll have it done. It was very painful, and I did not enjoy it at all. Internal trigger point therapy. So again, that intraoral massage, trigger points on medial pterygoid, maybe lateral pterygoid, and trigger points are just hyper painful spots within the muscle tissue. The trigger point doesn't do anything itself other than cause pain. Okay, so it's really the tightness of the muscle that precedes the trigger point, is what I'm trying to say. Now, as far as TMJ syndrome is concerned, of course, massage is indicated. We just mentioned intraoral massage, but we're not really going to be doing that, of course. We're going to be working the masseter and temporalis, right? The muscles that elevate the mandible. So we're going to be working here and here. And remember, we need to stay anterior on the masseter, not way back here, okay? We are also going to be working the muscles of the neck because, as you know, the neck attaches to the skull, or muscles of the neck attach to the skull right behind the joint, and can affect the joint. So it's not just the temporomandibular joint that's involved here. The neck gets involved as well. And of course, those muscles that attach directly to the joint capsule. So taking another look at this, the joint capsule here is supposed to stay where it is, right? But on the condyle here, you have an articular disc. It sits within the joint. Let's see if it'll, there it is. That's on page 236. So here's the articular disc. Sits within the joint. Here's the condyle. Okay, there's synovial fluid in here. This is a synovial joint. So what happens is this whole piece here slides forward. Okay, and when you open your mouth, it's supposed to slide forward. So it slides forward slightly in, this direction towards the lateral pterygoid. And that is what it is supposed to do. However, in the case of TMJ, when this becomes inflamed, the articular disc actually starts to break down. And when it breaks down, it doesn't do its job as well. And so the condyle then actually starts to slide forward out of the joint space and up against this piece of bone right here. So instead of staying kind of where it is and just moving a little forward, it comes too far forward and hits this piece of bone. And that is the clicking sound. Whenever you go, and it goes click, click, it's grind, grind against that bone, okay? Not a good thing, obviously. And if you are young and you already have this clicking, well, you might want to figure out some solutions because it's only going to get worse, unfortunately. This is progressive, so it is degeneration over time. It can be very slow and you can, have it for years and years and years. I actually know somebody who had to have a condyle replacement because their TMJ was so bad that the whole joint was just completely worn away. So they actually had like a knee replacement or a hip replacement. They had to replace the condyle here for the jaw. I can't even imagine. I can't even imagine. So that is the deal with TMJ syndrome. So it's not something that you want to let go forever. Some people have it pretty severely. Some people, again, it's really mild and it probably never bothers you and maybe never will. But for those of you or for your clients who have it really bad, it will cause headaches and jaw pain and all kinds of issues. And you can help with it, but they're going to need to maybe have some other interventions as well. Okay. So I'm saying you're not necessarily going to fix their TMJ syndrome. Okay, so that's it for those disorders. Now, the last one, of course, is thoracic outlet syndrome, which we already had in a previous chapter. However, I had mentioned that we would talk about it in a little more detail now that we have all the pieces of the puzzle. So we have the scalenes now, right? They're here. The scalenes, of course, are on either side of the brachial plexus. The brachial plexus, of course, goes in between those, dips under the clavicle, underneath pec minor, under coracobrachialis, and then down the arm where it becomes the ulnar nerve, the median nerve, and the radial nerve, okay? If somebody is experiencing numbness and tingling in their hands, like carpal tunnel syndrome, it may not be carpal tunnel at all. It may be coming from the neck. quite honestly, as a therapist who's been in practice for the last 20 years, more than not, I have seen that numbness and tingling in the hands comes from the neck. I have quite a few clients who've been experiencing those kinds of symptoms, and we started at the neck and that cleared them up. Okay. So that is what you will do as a massage therapist. You will start with the muscles of the neck, work your way down to pec minor, coracobrachialis, and then down into the hand. You also want to explain to your client while what you are doing and why you are doing it, because they're going to say to you, well, my symptoms are my hands. Why are you working my neck? Explain to them that the nerves that innervate the hands start up at the neck and you are working your way down step by step. Okay. They'll think that you're brilliant and they'll reschedule, and you will most likely help them with their issues. That is the thoracic outlet syndrome umbrella. It is a combination of anterior, it's called scalenus anticus syndrome, anterior scalene syndrome, pec minor syndrome. It's all under that thoracic outlet, or TOS as it's abbreviated, umbrella. Okay, so TOS isn't just one thing, it's a combination of different things, but ultimately it means that the brachial plexus and the artery and vein are pinched off and are creating symptoms, numbness, tingling, paresthesia, all of that kind of stuff. So for your information and to pass it along to your client, make sure that you start at the neck and work your way down instead of working at the hand. Okay, very important. And that's all I'm going to say. If you have any questions or comments, you can post them in the discussion board. Have a nice day.